First, I want to thank Professor Shander for his kind invitation here to speak in front of you about our baby blood management, this time from the Israeli perspective. When I read the invitation, I was stressed, very stressed. I must speak in English. When I speak in Hebrew, it's very difficult to understand me. What happened when I speak in English? The audience must understand my English, spiced by a heavy Romanian accent, blended with a Hebrew one. And the worst, you can sleep if you don't understand me. What about me? I was stressed, but I am not anymore. 6 weeks ago, during my last trip in your country, I saw on an optometrist door this notification. We speak English too. No problem, I said to myself. In USA, they speak English too. I understand. In USA, English is optional. Now I am relaxed. About Dr. Masad Baroum. Dr. Masad Baroum is the general director of our hospital, and he gave and gives me entire support. And without his help, I could not have introduced the project of restrictive blood transfusion. Now, a short story about me and blood management. How I fall in love with blood management. I grew in a small town in Romania, 15,000 people probably. The single hospital in those days had 200 beds. No blood bank in this hospital. When a blood transfusion was necessary, a small plane flew from the big city, capital of Romania, Bucharest, and delivered the bottles with blood with a parachute in the huge garden of the hospital. My father was the director of the hospital, and I was every day present in this garden. I was 5. The biggest pleasure for me was to run and find the parachute in the garden and to deliver the precious blood to my father. This was the primary scene. About 15 years ago, a contact was established between the Jewish community in Englewood and the Israeli town Nahariya, 40,000 inhabitants. From medical point of view, the same relationship was created between Englewood Hospital and Nahariya Hospital. This is the picture of our hospital, 650 beds. And he served 600,000 inhabitants. The flag, from medical point of view, the same relationship was created between Englewood Hospital and Nahariya Hospital. The flag of Englewood Hospital is blood management, bloodless medicine, and the flag of Nahariya Hospital is a multiple trauma treatment in a mass terrorist attack. So, very soon, doctors from Englewood came to Nahariya to learn about trauma, and Israeli doctors came to Englewood to learn about bloodless medicine, an unknown practice in our country. 5 years ago, I visited your hospital and learned about this technique. I understood rapidly that bloodless medicine will be very expensive and unnecessary in Israel, but a restrictive policy of blood transfusion will be appropriate. Here you can see definition of the blood. Now, briefly, about blood and blood transfusion history. Only 5 minutes. I think the past is very important to doctors involved in patient blood management. If you have a past, you have a future. The Greek have always known hema, blood, as a red fluid of the human body. Greek scientific consideration about blood dates from Homeric times. The ancient Greek considered hema a synonym of life. According to many linguists, the Greek word aima is the root of hema. Galenus, 200 years BC, before 2002 years, offered as a definition of blood. Hema is a substance which is less in the arteries and from which the animal is fed. He was the first to think of blood transfusion as a therapeutic procedure, 200 years BC. As for identifying blood with psyche, soul, this is not a Greek discovery. The idea can be found in the Holy Bible. The life of creature is in the blood. Blood plays a significant role in Greek mythology, too. Also, the Greek gods did not normally like blood sacrifices. Men must have recognized that loss of blood was frequently associated with weakness and death. If the belief was blood is so important for the human body, how can we explain that the therapeutic use 2,000 years ago connected to blood was bloodletting? The practice of bloodletting began around 3,000 years ago. And today in Western medicine, it is used only under a few conditions. In order to understand this, it is necessary to understand the paradigm of the disease 2,300 years ago. Being ill meant having an imbalance of the four humors: blood, phlegm, black and yellow bile, and the treatment consisted in removing an amount of the excessive humor. This is a picture of bloodletting. Famous, uselessly and repeated bleedings in history of medicine leading to death were to the Charles II and George Washington. I hope you know George Washington died in 1799 after epiglottitis, and his doctor treated him by 4 or 5 bloodlettings. The transfer of blood from the circulation of one individual to that of another for practical therapeutic purposes is blood transfusion. Also, it only became a practical possibility during and shortly after the Second World War. The concept of transfusion has a longer history. Early attempts of replacing lost blood involved the drinking of blood by the patient. The legend of vampire originates from this concept. On the right is the castle of the vampire in Romania, in Transylvania. There are a lot of blood myths. Here, only 3 here. Blood helps my patient get out of hospital sooner. Not true. Blood improves healing. Not true. Mosquitoes prefer sweet blood. No. This somewhat mystical fascination with the properties of blood is, to some degree, still with us today, being one reason for the difficulty to adopt a policy of restrictive blood transfusion. The real scientific revolution was in 1628, when the British William Harvey showed that blood circulation is within a closed system and described the mechanism of both systemic and pulmonary circulation in humans. This is Malpighi has completed Harvey discovery by describing the capillary system. About the etiology of word transfusion is in the late Latin word transfundo. Actually, first blood transfusion was in Pope Innocent VIII in 4030, who lives between 4032 and 4092, and he drank blood of 3 boys. He died. Dr. Jean-Baptiste Denis, a young French physician from the Louis XIV staff, performed a transfusion from a lamb to a 15-year-old boy. The boy felt a very great heat along his arm, a present-day indication of an incompatible transfusion reaction. Following this disaster, blood transfusion from animal to man was decreed in France as a criminal procedure. This decision was adopted also in England and by Vatican. Following those decrees, the practice of blood transfusion fell into general disrepute for more than a century and a half. The credit for placing transfusion on a scientific basis must be given to James Blundell, an outstanding obstetrician of his day. Many people regard Blundell as the father of modern blood transfusion from man to man. In the right, you have the impeller, an instrument for the blood transfusion in those times. Of course, his first transfusion of Blundell was done in a man and who died 56 hours later. The discovery in 1900 of the human ABO groups by Karl Landsteiner was a major step in understanding the origin of blood transfusion reaction. The first academic institution devoted to the science of blood transfusion was founded by Alexander Bogdanov in Moscow in 1925, and the first blood bank in USA was created by Bernard Fantus in Cook County Hospital in 1937. Now, the question, is blood safe? You have here a very short list about infectious problem with the blood. Also, human error, incompatibility reaction. About this, you have heard today a lot of. Is a blood transfusion good or bad? This is a question. Why to transfuse? Blood transfusion has only one goal, to increase the oxygen carrying capacity of the body. Dr. David Crombie, Jr., Chief of Surgery at Hartford Hospital, candidly admit I was raised in medicine at a time when blood was thought of as a tonic. Now it's thought to be a poison. This is true for 1996. Dr. Charles Huggins, who is the director of transfusion service at the large Massachusetts General Hospital, made this very clear. Blood has never been safer, but it must be considered unavoidably non-safe. It is the most dangerous substance we use in medicine. One of the most pervasive rules in transfusion medicine has been, and to a certain extent still is, that a patient should be transfused if the blood hemoglobin concentration is less than 10 gram. Why 10 gram? Why 10? It's incredible. But in a scientific medicine journal, it's a very good explanation. The number is easy to remember. We are a decimal society, so the number 10 has great significance to us. It's real, in a medical journal. Most clinicians agree today that patients are at increasing risk as hemoglobin concentration falls before 6 gram. Why do we treat? This is the most important slide. A question for the doctor. What do you treat? What do you treat? The patient, his lab report, or your own anxiety? In 1958, before 55 years, the editorial in the Blood journal Blood was misuse of blood transfusion. Thoughtless prescription of blood transfusion is playing a Russian roulette with bottles of blood instead of revolver. Actually, blood transfusion is the silent epidemic. The decision to transfuse is influenced by the way blood transfusion is viewed in society. But, which is the real trigger, the critical hemoglobin for tissue oxygen delivery is not known. The possible result if we overuse blood transfusions is dead but transfused. Transfusion is in a sense a transplant of allogeneic cells, and its risks, also modest, are not negligible. So what is the minimum level of hemoglobin that can be tolerated by a healthy individual? The answer is unknown. Actually, why to reduce the number of blood transfusions? Blood transfusions are common, are costly, increase morbidity and mortality. Some more. Blood transfusions are unnecessary, and RBC transfusion decisions are predominantly based on hemoglobin levels rather than on patient characteristics. Primum non nocere. A restrictive policy instead of a liberal one can cause a dramatic reduction in blood requirement without endangering the safety of the patient. Obligatory step. First step is to interest and recruit the medical administration in this kind of project. For the administration is very important. It's economical point of view. Second step, to assign a blood transfusion coordinator. This is very, very, very difficult. You must find a med doctor, like me, who is on call 24 hours a day, 7 days a week, to approve every PRBC. Third step, a review daily report of blood released by blood bank to departments. Fourth step, note the departments that give more blood transfusion than the median consumption. Fifth step, discuss the real necessity to transfuse a patient with the doctors from departments that traditionally over-transfuse. The need for a transfusion was based on the patient's underlying illnesses and symptoms and on the developing rhythm of anemia, not only on the hemoglobin level. The benefit of blood transfusion was also taken into consideration. Blood transfusion approval was in concordance with evidence-based medicine facts and blood transfusion guidelines of different medical institutions around the world. Sixth step, generalization of restrictive policy to all medicine departments. Additional measures, continuous education in the field of restrictive policy of blood transfusion, retrospective discussion about cases in which blood transfusion was refused. Results. 3 months after introduction of restrictive policy in my hospital, 3 months, a blood transfusion drop of 56% without harm to the patient. According to the professional literature, restrictive transfusion practice improves patient outcome. The biggest reduction was indeed in the wasting departments, but a reduction was observed also in other departments. You can see I started 5 years ago, and of 1st of July. You have in all internal medicine department 200 portion per month, and after my intervention, 87. You can see in the first column all the internal departments, and from right to left, internal medicine A, B, C, D, E, F, and in here, you see from 51 to 11. I was very surprised to see that in literature is a few articles discuss about internal medicine department, and the big consumption of blood transfusion in useless blood transfusion is not in surgery, is in internal department. Once every 2 years, I organize in our hospital an international conference on this subject, restrictive blood transfusion. The participants are leading specialists in the field, like Professor Shander, Professor Arnold Friedman, and Professor John Friedman, who are present here today. And also visited us Professor Goodnar, Professor Weishaupt, Professor Carson from USA hospitals. The situation today in Israel, we have a society for alternatives in blood transfusion medicine, whose honorific president is Professor Shander. And the policy of restrictive blood transfusion is penetrating slowly but surely in several hospitals. In 2 years, in 2015, it will be possible to organize the European Congress of NATA, the equivalent of SABAM, American SABAM, in Tel Aviv. Thank you for